Hello viewers, good evening all. I welcome you all on behalf of Indian Medical College to this online class on the topic Typhoid. This has been discussed by Dr. Arunagiri Ramesh from Velamal Medical College, Madurai. There is a pre-recorded video of his presentation. So if you have any doubts or any clarification, please type them in the chat section of this video streaming live in the YouTube or at our Facebook page. Your queries will be clarified later on. Thank you so much. And dear viewers, please fill up the feedback forms given in the chat section. So now we'll push on to the topic.
Good evening, students. So this is a microbiology class which deals with a bacterial infection as a clinical case, and I am Dr. Ramesh, Professor of Microbiology. A 45 years old male who is a salesman who travels frequently, complains of fever, pain abdomen, nausea, vomiting and anorexia for the past 10 days. On examination, he has fever, hepatosplenomegaly, coated tongue. So what is your possible diagnosis and what could be the possible differential diagnosis? So we'll see what are the possible DDs for this brief history in our country's context. Okay, so possibilities are: it could be a typhoid fever, it could be a malarial fever, it could be an infection with the brucella causing brucellosis, or it could be a dengue fever. So these are possible common causes in our country. You can also include it. Good evening, students. So this is a microbiology class. Good evening, students. So this is a microbiology class which deals with a bacterial infection as a clinical case, and I am Dr. Ramesh, Professor of Microbiology. A 45 years old male who is a salesman who travels frequently, complains of fever, pain abdomen, nausea, vomiting and anorexia for the past 10 days. On examination, he has fever, hepatosplenomegaly, coated tongue. So what is your possible diagnosis and what could be the possible differential diagnosis? So we'll see what are the possible DDs for this brief history in our country's context. Okay, so possibilities are: it could be a typhoid fever, it could be a malarial fever, It could be an infection with the brucella causing brucellosis, or it could be a dengue fever. So these are possible common causes in our country. You can also include TB, but it is not classical of TB here. So how to rule out one by one? Let us take up first malaria. So peripheral blood smear at the time of defervescence, when there is just before a rise in temperature, if you take a peripheral blood smear, you can see whether the parasites are there. If the parasites are not there, well, you can rule out malaria. Second comes a dengue. Dengue is a more of a seasonal disorder associated with the rains, but even though it is there throughout the year, but it's more common during the seasonal times like September to January or February. And an easy serological test can say out whether the test is positive or negative, whether you can detect NS1, IgM or IgG. So ruling out these two, we have in hand. So it could be brucellosis or a typhoid fever. So why we are considering here both? Because they closely match each other. Of course, there are certain classical differences between them. So first one is a fever, which is called as a stepladder fever in typhoid fever, which is an undulating fever in brucellosis. Please remember, when the patient comes, he or she doesn't know what is stepladder or what is undulating fever. So that is the reason why we have to be very cautious. But both the fevers involve reticuloendothelial system, and musculoskeletal system commonly is involved in brucellosis rather than in typhoid fever. For both the cases, we do a blood culture. Of course, most of the time it is not very sensitive test, but it is a gold standard in case of typhoid fever. Brucella takes a much longer time. It takes more than a week or sometimes even up to 14 days for the organism to grow. But Salmonella grows within a span of a week's time, maximum within a week's time. And of course, to confirm, we have one more serological test, that is a Vidal test for typhoid fever and an IgM IgG detection test for brucellosis. And moreover, brucellosis is more commonly associated with a close contact with cattle, animals, either they are milk or milk products or whatever. Whereas a typhoid can be that way too. In spite of that, it is more commonly associated with food, what we consume after cooking. So it can be any type of food, even an ice cream can cause this infection. So the most likely diagnosis here, we come to conclusion, it is a typhoid fever. And please remember, an untreated case of typhoid usually lasts for 4 full weeks. So microbiological investigation depends upon which stage of illness the person is presenting to us. So please remember the short form BASU. So if the person is in the first week of illness, the best diagnostic modality is blood culture. Second week of illness, we prefer an antigen antibody test, commonly called as a Vidal test. Third week, it is a stool culture, it is always better. And fourth week, it is always a urine culture, which is always better. Sometimes we may need to take even a bone marrow aspirate as a culture when we have a blood culture as negative, but a strong suspicion of typhoid fever is there. In case of carriers, we always go for a bile culture. So from gallbladder, we aspirate the bile, and that bile culture is taken into consideration for diagnosis of this particular disease. Sometimes what we do is a clot culture, because this organism is an intracellular pathogen, so it is present inside the blood clot. So what we do, we break the clot so that the organism is released from the clot, and such culture is called as a clot culture. It is sometimes better than a blood culture. So coming to the laboratory diagnosis. So as I told you, the first week we go for the blood culture, where 90% positivity is a chance, provided the patient has not been exposed to antibiotics in the recent past. Second comes the clot culture, comparatively higher isolation because of the release of intracellular pathogen. The media we use here is the brain heart infusion broth, which we see there in the panel. And sometimes we use what is called as a Castaneda's biphasic medium. Nowadays we don't use it because we have automated cultures. So blood cultures are incubated at 37 degrees centigrade for 24 hours up to 5 to 7 days. And even after 5 to 7 days, what we do, we subculture on a blood agar and on a McConkey agar. In blood agar, we get non-hemolytic colonies, and in McConkey agar, we get non-lactose fermenting colonies. So usually, please remember, when you get a non-lactose fermenting colony, especially from a stool sample, I'm not speaking about blood here, I'm speaking about a stool sample. So always think about important pathogens like Salmonella, Shigella and Vibrio. Okay, an NLF from a blood culture, yes, it could be Salmonella. Very rarely we see Shigella in blood, and of course Vibrio is quite rare. Of course other NLF are there like Pseudomonas and all, but here, pertaining to the history, an NLF in McConkey agar goes in favor of Salmonella. So this is a biphasic Castaneda medium where you can see a liquid broth and a solid culture on the side of the container, where subculture can be done without having any minimal access to the bottle. So just you twist the bottle upside down, subculture is done. You need not open the cap and inoculate the needle again, so causing any culture contamination. To avoid this, we have a Castaneda's biphasic medium. So we have certain specialized agar where SS agar stands for Salmonella Shigella agar. So where Salmonella produces black colonies. So these are due to the presence of hydrogen sulfide. Shigella doesn't produce any hydrogen sulfide, so it presents just as colorless colonies, whereas Salmonella produces hydrogen sulfide, so it has black centered colorless colonies. Whereas deoxycholate citrate agar on the right side of the panel, there is DCA, we have NLF colonies with a black center, again the same principle, where Salmonella is releasing H2S, causing black color. XLD agar, that is xylose lysine deoxycholate agar, sorry, where you get red colored colonies with a black center. On the left side of the panel you can see a Shigella growth, just a red color colony. On the right side you can see a red color colony which is masked by a black color growth, that is due to the presence of H2S. This helps to differentiate whether you are dealing with Salmonella or Shigella. Wilson-Blair bismuth sulfate medium, a commonly asked viva question. WBS, Wilson-Blair bismuth sulfite medium, produces jet black colonies with metallic sheen on a green background, typical of Salmonella typhi infection. So as I told you, we can also have a bone marrow culture, a duodenal aspirate. Sometimes in fair-skinned people you get to see what is called as a rose spots, CSF, sputum, and very rarely from autopsy. Nowadays people don't die of Salmonella. So you can get a gallbladder, liver and spleen. When you do a culture smear, whatever the media you have used, you do a culture smear, you can see a motile gram-negative bacilli. So Salmonella is a gram-negative bacilli and it is a motile. So this motility is an actively motile organism with the help of peritrichate flagella. So Salmonella comes under Enterobacteriaceae. The cell wall antigen is made up of O antigen. Actually it is a mosaic of antigens, combination, and which adds a specific H antigen. So H antigen stands for the flagellar antigen. So these two antigens are utilized in our Vidal test. So biochemical reaction, please remember glucose and mannitol is fermented. Indole, lactose, sucrose fermentation is negative. Phenylalanine deaminase is negative. Citrate is utilized. When it comes to TSI, it is K by A, alkaline slant by acid, but with a speck of H2S production. So this helps you to differentiate between Salmonella typhi, paratyphi A and B. As in case of typhi, we have speck of H2S. In case of paratyphi, it is K by A, no H2S. So A stands for absence of H2S. And paratyphi B, K by A with abundant production of H2S. So abundant, B for abundant, B. Whereas your classical Salmonella typhi has K by A with a speck of H2S production. So based upon the biochemical reaction, the organism can be identified as Salmonella. It has to be confirmed by an agglutination test where you use a polyvalent O and a polyvalent H antiserum against Salmonella. So depending upon the clumping, you come to conclusion whether it is Salmonella typhi, paratyphi A or paratyphi B. So sometimes what happens, there is one more antigen called as VI antigen. So this is commonly seen in the fresh isolates of Salmonella typhi, so which are non-agglutinable with O antisera. So what happens here, you may get a non-agglutination reaction in spite of being Salmonella typhi. So you have to boil the culture sample to some extent so that this VI antisera and this effect can be completely removed. So the common test which we do in the lab is the Vidal test, where we go for a serial dilution. So we have different types of antigens here. As I told you, now we have commercially developed blue colored O antigen and pink colored H antigen. So there is only one O antigen for the whole Salmonella, whereas H antigen we have H, AH as well as BH. So H stands for Salmonella paratyphi A, BH for Salmonella paratyphi B, and H stands for Salmonella type B, and the H antigen stands for flagella antigen. So we go with the patient serum and the antigen by serial dilution, starting from 1 in 20 up to 1 in 640, sometimes even up to a higher value. A titration value of 1 in 80 and above in our endemic status condition of Indian standards is considered to be positive for both O as well as for H. Some books call it as 1 in 162. Doesn't matter. But the more important one is, you should always test this particular test with a paired serum sample. Suppose the second week you do this test, subsequent week after a week's time, you get another serum sample and test it. There should be a rise in the titer. So that indicates that it is specifically Salmonella typhi infection. So when there is a O agglutination, it is a compact agglutination which has a granular chalky clumps. It presents as a button-like or disc-like appearance with a clear supernatant. So O antigen is the one, O antibody is the one which appears first and disappears first. Comes early, leaves early. H agglutination on compared to O is a loose, fluffy, cotton woolly clump with a clear supernatant, appears late and as well as disappears late. So interpretation, as I told you, O 80 and above is positive, H 160, 1 in 160 and above is positive. So this is typically based upon the epidemiological parameter. This cannot be applied to Western countries where the titer value, even low titer value, is still significant. This is exclusively for our Indian standards. So how will you give for an interpretation? When there is a rise in O and H antibody, yes, entry fever. Rise in O and AH is paratyphi A. O and BH paratyphi B. O alone, it could be a recent infection of type E or paratyphi A or paratyphi B. H alone is raised, it may be a convalescence sample because H antibody appears late and disappears late, or it may be an anamnestic response. When there is a rise in all the values, all the four, H, BH, all, then it is a post-typhoid AB vaccination, oral vaccine. So false positive can come in anamnestic response, that is, antibodies which are closely related to the Salmonella antigen may be present, or there may be an inapparent infection, or there may be a vaccination. A false negative can occur in very early phase. As I told you, antigen antibody reaction should be done during the second week. Suppose 2 or 3 days after the history of a fever, if you do a viral test, it may be negative, or 2 or 3 weeks, 3 to 4 weeks after the illness, still you may get a negative. So too early or too late, or presence of antibiotics in the patient's serum, or maybe due to a prozone phenomenon, excess antibody effect. So other tests are, which mainly detects the antibodies, include Typhoid test, which detects both IgM and IgG, ideal Tubex test, which detects only IgM. There's a dipstick test, IgM dipstick test, and there's an ELISA, which detects the antibody against the lipopolysaccharide, that is a O, cell wall O component, has a component called lipopolysaccharide. So all gram-negative organisms have this lipopolysaccharide, which is responsible for the endotoxic effect, and it detects the IgM. And dot blot assay, which detects IgG, and of course we have some antigen detection tests like ELISA and countercurrent immunoelectrophoresis, but usually we don't do these tests so commonly, except for this Typhoid and dipstick test. Commonly we do is a viral test as well as a blood culture. Certain non-specific conditions. So you should remember, any infection is considered to be associated with a high fever, as well as a fever can also be associated with, an infection can be associated with neutrophil rise. But here you get a neutrophil fall. That's called neutropenia. The reason is, this is one of the organisms which classically attacks the reticuloendothelial system. A word about the fever. So here we have what is called as a stepladder pyrexia. There may be a steady rise of temperature in an untreated case on day-to-day basis. There's one more term which is closely associated with salmonella, what we call as a relative bradycardia. What is this? So when there's an every 1 degree Fahrenheit rise in temperature, the pulse rate increases by 10 beats per minute. But this rule is not applicable in salmonella infection, where the temperature rise doesn't go in parallel with the heart rate. The reason is, probabilities as hypothetically it has been told that there are certain toxins which will inhibit the heart rate. Of course, there is leukocytosis, there is increased liver and muscle enzymes. So this can sometimes confuse us with hepatitis. So you should be very careful. So we have separate hepatitis markers, so that can be considered as one of the differential diagnoses. So hepatitis markers will be able to differentiate between typhoid infection and hepatitis, where you may get a positive blood culture in typhoid, which may not be possible in a hepatitis infection. So carrier detection. So you might have heard about a person called Typhoid Mary, who was responsible for a series of outbreaks of typhoid infection in the United States because she was a food handler. So most of the time we get a typhoid fever from a carrier who is a food handler. So in a carrier, what we do a blood culture, we can do a bile culture, sometimes even a urine culture. Nowadays, as a NABH norm, you might be knowing about what is NABH, National Accreditation Board for Hospital. We do this culture for even for food handlers in our hospital who are working in the canteen or handling the food. So we usually do a stool culture. So we do what is called the VI antibody tube agglutination test. So this is called, so we told about VI antigen, which comes in the way of agglutination. So we detect for this VI antibody, a titer value of 10 and above is significant. And the CVS swab technique, this is usually followed in most commonly in Western countries. So not much important here, only when there is an outbreak we do this technique. And a millipore filtration method. See, these are other methods where we do for carrier detection. So treatment part, the recommended drugs today we use quinolones, fluoroquinolones, third generation cephalosporin, azithromycin. So nowadays we are commonly seeing multi-drug resistant salmonella. So they are resistant to a COT group of drugs. They are called as a COT group of drugs: ampicillin, cotrimoxazole, chloramphenicol, and tetracycline. So these drugs. So there is one more resistance called NAR resistance. NAR stands for naldixic acid resistance, as well as for ciprofloxacin resistance, quinolone resistance. So resistance to CTR, that is ceftriaxone. So this is a extended spectrum beta lactamase resistance, as well as AMC resistance. So these are all the different mechanism of resistance by which salmonella is exhibiting against the human host. So prophylactically, we have control of cases. So that is early diagnosis and appropriate treatment, proper disinfection of excreta, and very important, follow-up of culture sensitivity to detect carriers. So the detection of carriers is the key point here. So we have to control the carriers. What we do, as I told, we can take a stool sample, urine sample, culture, look for VI antibody detection, see if it is 10 or more, and we can give them ampicillin or amoxicillin, plus they can go for cholecystectomy. So this is one condition where is indication for cholecystectomy. Most important community measure is a sanitation measure. So we do have certain vaccines. So usually, who are all the people who should be vaccinated? People traveling to endemic areas, pediatric age group individuals, people living with household contacts, people in endemic zone. This is optional. Usually we get a somewhat herd immunity, but don't worry. So we have different types of vaccines. We have a parenteral TAB vaccine, nowadays not in use. Parenteral VA polysaccharide vaccine, which is given IM or subcutaneously, it gives protection for 2 years. And we have a Typhoid oral vaccine, TY21A, which is a live attenuated oral vaccine, which offers protection for 4 years and boosters required every 3 years. Thank you.
I convey my heartfelt thanks to Dr. Ramesh for a wonderful session. Dear viewers, I hope you all are benefited by this interesting session on typhoid and the clinical scenarios mentioned by Dr. Arunagiri Ramesh sir. Kindly fill up the feedback form which has been given in the chat section below, and stay tuned for the upcoming interesting sessions. Kindly share our YouTube channel and our Facebook page. There are a lot more interesting talks by our experts upcoming session today. And so our upcoming session takes place at 6:30 p.m. today. And the topic for the session is A to Z of ECG, which has been delivered by our beloved Dr. Vinod Doraiswamy from PSG, Coimbatore. And here is the schedule for the tomorrow's classes. So tomorrow's class, the session starts from 3 to 4. The topic will be free radicals and antioxidants. It has been delivered by Dr. Vasan Gosai from GMS Medical College, Darpur, Patan. And the session 2 starts from 5 to 6 p.m. The topic for the session is blood transfusion, which has been delivered by Dr. P.S. Sharma from KIMS Amalapuram. Followed by the session examination of the pupil by Dr. Rachula Daniel from SRM Medical College, which will be taken by 6:30 to 7:30 p.m. Kindly share the session through the link of Facebook, YouTube, and subscribe to our channel to know about the upcoming sessions. Thank you, viewers.